Cool.
Hello again. Right. Here we go. So thanks very much for coming to the last session, and we're just going to share our experiences as well at the end of this. So I'm going to share my screen and just load up the presentation. Screen. Go. Okay, can everybody see the PowerPoint slides? Can you see the PowerPoint slides? Just put a thumbs up or something.
We can see that you've shared the screen, but it's coming up blank at the moment.
Ah, that's a bit weird. That is weird.
Ah, that's working now.
Oh, there you go. For some reason, it paused it as soon as I shared it. I don't know why that happened. Okay, here we go. So we're going to talk about adverse events, about reporting adverse events. So it's something that can happen. And it's not just an important thing for healthcare professionals directly treating patients, because also managers and admin staff and all that get to be involved in sort of complaints and things like that. So we're just going to whiz through this and kind of just touch on the more interesting bits of. We're not really going to sort of have a proper lecture as such. So when something goes wrong, there's four main things we have to do. We have to make sure the patient's okay and care for them and provide any additional care that they need because of whatever's happened, be it a complication of treatment, or they've slipped and fallen, or they've had a delay to care. They're just on the waiting list. We need to communicate with the patient, and sometimes it needs to be reported to appropriate parties. Certainly internally always needs to be reported, and it also needs to be documented. Can anybody, with regards to an adverse patient instance, or a patient has suffered as a result of being in our care, suffered an injury or harm or something like that, who do you think it should be reported to? Does anybody know sort of the chain of escalation for that?
Well, safety first initially. And the line manager of the staff involved will receive documentation through safety first. But depending on the severity of the injury and the harm, it may get escalated external to the organisation.
Yeah, correct. Yeah. So I think it's always a good idea to, if you noticed something that's caused harm, is to not only report it safety first, but also talk about it with line manager, colleagues and stuff like that as well. Those safety first incidents get investigated by the quality and patient safety and risk team. And the investigation is held by a put together band of people who are independent, are like not involved in the incident, and will be able to interview people and try and come up with a good timeline of what happened, and then to identify opportunities for improvement. If it is a SAC 1 or 2, that means if it's something that's involved, resulted in the death or permanent harm to a patient, then a copy of that report also goes to the HDC, which is the main governmental body that oversees quality within the hospitals. And the HDC will then either just file it, or they may choose to investigate it if they think there are serious misgivings. That report would then be published either without naming the parties involved, or sometimes naming the parties involved. And if it's serious, then that can also be referred to the regulatory body, which in the doctor's case would be the Medical Council New Zealand, and then they may take a disciplinary action if they feel necessary. So that's the way it goes. So why is it difficult to communicate after an adverse event? Well, because there is a psychological need to preserve a sense of self, anger from the patient, you're afraid of that, or you're afraid you're going to lose your job, or that you're going to lose your medical practice, disapproval from other people. These are real things that are real barriers to reporting adverse events in the first place. Now, hospitals on the one hand really want to encourage adverse events to be reported because it's the only way that we can learn from our mistakes. If they were never reported, then they go unnoticed. So hospital systems like the patient safety and risk team want to go about their investigations in as much a way as to seem as little punitive as possible. In other words, to try and be completely open and transparent in saying that we're looking at systems failures rather than individual culpability. And that gets you most of the way down the line in terms of getting people to open up. But unfortunately, because this reporting system does have the HDC right at the other end, and even the regulatory body, it is a process that does actually have adverse consequences for some staff, and is a very minority of it, but it does happen. There is some personal responsibility in these cases, and so you can never get away from that. So whenever you investigate it, you cannot guarantee that somebody is not going to fall harm to the investigation process. What is known as the second victim is the person who is involved in the incident, but not the actual person who was affected directly. So it is a difficult area to negotiate. And one way to sort of get a sense of proper context is to always approach these situations with this sort of no one is perfect mantra. The fact that human error does occur. Everybody makes errors. It is part of being human, and you cannot do your job and expect not to make an error from time to time. And so the way to improve safety is actually to understand where the errors come from and change the system to prevent those errors ever occurring in the first place. The importance of communication with patients is probably the most important thing when it comes to when things have happened. Because I mean, we probably all know that if patients are well communicated about adverse events, the chance of them actually making a complaint or taking that complaint to a level that is serious for people involved, that risk goes right down. So nipping things in the bud in the right way from the right people is the best way to do it. Let's open up a little discussion. So who do you think is the best person to make that first communication with the patient?
I would have thought the person involved, ideally.
Yeah. So, but what if it is an organization involved? Say it's obvious that there's no one person's fault here. For example, a delay to patient's care. Who do you think would be the best person to think about it from the needs of the patient? What do you think the patient is really wanting, and who do you think they wanted to talk to? 9 times out of 10, it's their consultant, or it's their GP, or it's the clinician who was the main person in that care episode. From my personal practice is that I like to actually go and either phone the patients or see them myself, and just apologize, even if it's got nothing to do with me. If a patient's operation has been cancelled, I try and go and speak to them but I haven't managed to get to the bottom of this problem yet, because the staff usually send the patient home before I manage to get to see them. And that's an opportunity missed. But yeah, if a patient complains by letter, I usually try and get them into clinic and speak to them along with whoever their support person is, and communicate in the complaint. That usually clears almost everything up. Why do patients sue? Well, of course, they don't really sue much in New Zealand because we've got ACC, which kind of stops almost all of that happening. But they still complain. And the reason that they want to complain is because they're concerned about standards of care. They're concerned about other patients falling into the same problem. They're concerned about they just often are in the dark. They just don't know what happened, even despite people explaining it to them. Sometimes they just need time to go away and think about it, and then realize that they still don't understand. Then actually seeking compensation for losses is not a common thing, and wanting staff to actually be held account for their actions is also not a very common thing at all. So general guiding principles is just use your judgment. Timing does matter. So if the patient is currently trying to recover from an adverse event, it's probably not the best time to actually talk about it all. And it is sometimes better to reserve that until later, but an apology can still happen. And also sometimes if the severity is very low, then we don't need to communicate that with the patient at all. And actually by doing that, it actually just causes more upset when, you know, they've not been harmed, or there's nothing different is going to come about from it. So what should you say initially? We should say what happened. We should say what is going to happen. So how has it affected them? And actually saying the word sorry is probably a really powerful way to convey your empathy with them. And it doesn't actually acknowledge that you are solely to blame for it, or even that if you're blamed at all about it. It's actually just showing that you're somebody who can empathize with the other person and say, you know, if I was in your shoes, I would not like it either. And then also a promise to follow it up, because that's they don't want to be left high and dry. So when you're ready to apologize, that can be done in this order. And if you've done the groundwork before by sort of acknowledging it in the beginning and saying sorry, and then eventually you've come to realize that there's a part in it that you could have done better, actually this comes a lot easier if you've already done that groundwork. I wanted maybe to get some people to give me examples of how they might apologize for these things. Like you borrowed your friend's favorite shirt and lost it, or there were no beds in the hospital, so you had to cancel patient's surgery, and the patient unfortunately had traveled all the way from Monaco in the morning. So it was they've been really inconvenienced if nothing else, and obviously they're going to get a delay to their care. And another scenario is the patient's husband has written to complain his wife, who is in the hospital, is being ignored by nurses, but in fact she's actually just pressing the call bell all the time, and the nurses just can't keep up with the demand. So some different situations there. I was just wondering if just put on the chat just now if you don't want to contribute to this bit here. Otherwise, I'd like to maybe ask each of you to take one of these and then have a think about it. So just put on the chat if you don't want to be allocated. Okay, so we got 3 scenarios, and I'm going to say, Ross, could you think about the first one? Pam, could you think about the second one? Angela, could you think about the third one? So to help you think about it, I will show you the next slide, which is just a bit about that framework back there. You don't need to follow this if you don't want to, but it might help you. I'll just give you a couple of minutes to think about that, and then we'll start with Ross.
It's interesting for me because I feel like this has definitely happened to me a few times in the past.
Oh no, you're running out of shirts, perhaps.
Yeah. Or yeah, I was just thinking like it could be a shirt or just like anything. I remember once my friend gave me a $50 note to hold on to because they didn't bring their wallet with them, and I lost it.
Oh no.
I was holding it in my hand, and then all of a sudden I wasn't, and I was like, oh god, what happened? But I guess what I would do is I would like try to apologize as politely as possible and explain like why I borrowed it and probably the reason for the loss, and then say like how this is not very common, and I'm usually quite conscious and take care of other people's belongings, but and I'll try very hard to make up for the loss by either suggesting that I pay for a new shirt or whatever the item was that was damaged, probably purchase something similar for them just to say I'm so sorry.
Oh, you're a good friend. Yeah, I'm sure that apology would go down fine.
Yeah.
And yeah, I think it's one. This is something that's called a difficult conversation, and it's important to acknowledge that difficult conversations are difficult, you know, and if they go well, you can still feel like shit afterward, you know, even if it's a really difficult conversation and the outcome has not been good for either of you, you still feel shit at the end of it. So just knowing that can mean that you can go into the thing at least expecting to come out the other end not feeling like a bunch of roses, and that is okay. And it's okay to actually have that empathy and feel that sort of guilt and feel that, and then that also means that the reactions that you get back from the other person, which can be sometimes quite hostile or are a bit easier to swallow, because you know that is just the way it's probably going to go if it's a difficult conversation. But you've done your best. You've gone through it in this way. You've expressed remorse, or you've shown empathy, and you've given some way of reparation. You've done your best you could in that difficult conversation. Great, thanks, Ross. Pam, would you like to share with us your thoughts on how you might approach the second one about no beds in the hospital?
Unmute. Hello.
Hi.
If there's no beds in the hospital, well, I work in A-Day, and we normally have like queues and have a full waiting room.
Yeah.
And at the beginning, when you triage them, we normally say this at the front, we'll be quite honest with them, saying that we're very sorry, it's going to be a long wait. There's no beds in the hospital, and that's why we're so inundated with patients at the moment. So I think giving them a heads up as soon as they arrive at the workplace or in A-Day, then they sort of like, oh, that's all right. They sort of like understand you, and they can actually see that ED is quite full.
Yeah.
But then you sort of like give them options as well. If it's just a minor, like a minor thing that they want to see a doctor, you give them options to see urgent doctors or their GP or another GP service.
Yeah.
if ever.
Yeah.
Yeah.
Yeah. Wonderful. Wonderful. Yep. So you usually say sorry that there's a long waiting time. So you're acknowledging, you're explaining why, and you're giving other alternative options to try and fix it for them. Do you ever go for the third thing there about sort of like saying how this makes you feel?
Yes, I do.
Yeah.
You sort of like say that, oh, we have patients that have been waiting for so many hours on the bed, waiting in an ED bed, waiting to go up to the wards, and it's really frustrating for the nurses as well and the doctors, because they can't see any more people because there's no available space.
Yeah.
So
But
you
how
say
about,
that.
yeah, but do you say how it makes you feel?
Yeah.
Yeah.
I say I feel really bad because
That's great.
you don't have to have a patient for 20 hours on the bed and they're not comfortable, because the ED beds are really like hard on the body and causes like, no,
that's wonderful, because that's such a powerful thing, really, isn't it? As soon as you say that, oh, that just makes me feel bad, then you are one human connecting with the other person there and saying, no, I feel your pain, I share it with you. And then there's that sort of connection and that empathy, that direct empathy, that really does make a difference. Yeah, it's great. Cool. Thanks, Pam. Angela, would you like to have a go at the last one?
Yeah, so this one raises more questions than it answers, in the respect that the patient's husband has written. So the question is his wife still on the ward?
Yes, the patient's, they're still in hospital. Yeah.
Okay.
Yeah.
So I think a conversation is what's required rather than a letter, because sometimes I think it escalates things. No matter how politely you put something on a piece of paper, it can smack of ass covering. So
yeah, I would agree. This is one to just go straight and have a little chat. Yeah, absolutely.
Yeah. So in a conversation with not only the husband but the wife as well in the room, so that you can acknowledge their perspective and explain your own perspective, and say that you're sorry that that's how this situation has been interpreted by them, and that you're disappointed that you haven't been able to meet their expectations, and that you feel sorry for that, and make a plan going forward around what an appropriate protocol is around the patient's needs and how they're responded to.
Yeah, perfect. Yeah. I think this one is also slightly difficult because it does seem like the patient is being unreasonable, maybe, because they're pressing that call bell all the time, whereas, there is a certain etiquette about that.
Yeah, and I think you've got to wonder if they're, someone who's suffering from Alzheimer's, for example. So, that's what I'm saying. It raises more questions than it answers.
Yeah.
Because, yes, if someone's being impatient and belligerent, then that's an entirely different conversation.
Yeah. So usually this thing here is a good sort of reminder that all behavior is not random, and that all behavior has a reason. So if somebody is pressing a call bell incessantly, there is something driving that. And it could be that, I know, they're extremely nervous about being in hospital and they need constant reassurance, or that they've not actually had any information at all from their doctors, and they're not actually communicating that. They're just thinking that the nurses are going to keep looking after them and giving them information.
Hi, James. It's Sharon here.
Oh, hi, Sharon.
I just wonder too, on that last one, I was thinking the same, that it seems as though the patient, there are other issues at play with that patient.
Yeah.
I just wonder in this sort of circumstance whether you can sort of use the patient's husband or enlist their help and say, well, can you help us? Is there something that we should be doing, or is there something you can tell us about the way she behaves, or can you give us any ideas of things that we could do to help you know, with that sort of incessant bell pressing. So there might be something that sort of get them on board to actually sort of try and solve the problem, because it seems to me as though there is some other things in play, like whether she's up nervous or it reminds me of that sort of that escalation of concern about patients where the family often have insight into the health or well-being of a patient that you know, carers in the hospital perhaps don't understand or know.
Perfect. I really like that. And that's turning it into a win-win. So when we talk about negotiations, and this is a particular form of negotiation, you can either have a negotiation where there is a piece of the pie, a one pie, and you are trying to fight over how much you get. And that's one mentality. And therefore, there's always going to be either a winner or a loser, or two half winners, half losers. But what you're describing there is where you actually, instead of sitting on opposite side of the table, you go around and sit on the same side of the table. And now you're collaborating around the problem rather than actually competing over it. So that's a really, really good example of turning a conflict into a win-win situation. That's good. Right, we'll move on. So yeah, we'll move past that. We've all had how would you feel? Yeah, well, I mean, there's all these sorts of emotions that we've touched upon in terms of how you would feel. So this is a bit about what I mentioned about the second victim. So the person or the individual who delivered treatment that ended up in harm or whatever, or the involved parties might actually feel quite guilty for it. And it can actually lead to changes in practice, which may not benefit for future patients. And it's important to recognize when your practice is being changed because you think the evidence supports a change in practice, or when it is actually a knee-jerk reaction to one or two anecdotal things. Can anybody think of ways in which we can protect mainly clinicians, we're talking about here, from changing their practice in knee-jerk responses? Okay, so I'll Angela, you about to say something?
I was just going to say, if they feel supported and not blamed, if they're working in a sort of supportive culture, they're less likely to behave that way.
Correct, yeah. And what would that supportive culture look like?
It wouldn't be a competitive environment. It would be a collaborative one. It would be where there was a flat hierarchy and practice was collaborative, and there was an opportunity to share the equivalent of an M&M. So, you know, where you regularly revisited things that went suboptimally and discuss them as a group with a no blame sort of focus.
Yeah, perfect. Yeah. I think that's probably one of the keystones of this is mortality and morbidity meetings, where there typically is a completely blame-free culture in those settings, because it is amongst your peers, and your peers understand just how easy it is to make errors the way you have done. To a point, of course. I mean, if one of your colleagues is actually like a shipman or something, then you might actually get a finger pointed at you eventually. But in the vast majority of scenarios in M&M, we'll see clinicians bringing their worst things to the table for support and for advice. And that is where you can then hear from other colleagues saying, well, I would have done the same thing if that situation occurred to me, and it sounds like this is just, you know, one of those things. Or they may say, no, I usually do something different. So an example for me is when I started recently here, and a paper came out on a different technique for closing the abdomen after a laparotomy. It's called the small bite technique, and it came into practice after a large randomized controlled trial showed that it was better at preventing hernias after the operation. So I and a lot of my colleagues have adopted this practice, and I've started using it on all my patients. But then one of my patients came through the M&M, and I said that this patient suffered a wound dehiscence, so that it came apart. Within about a week of the operation, which is not a good complication. It's correctable, but it's not good. Through sharing that with my peers, I could have thought, well, maybe this small bites technique, I'm not getting it right, or maybe we shouldn't be doing it, or something like that. But then actually through the discussion, I realized that actually the randomized controlled trial was not validated for emergency patients. It was only validated for elective patients. And that, the biology of patients who are undergoing emergency surgery is probably different, and their healing rate is different, and that this closure technique might actually not be superior in that group of patients. So that I did change my practice after just one case, but that was after a peer review. And they said, well, actually, we went through the same, we noticed the same thing in our department a year ago. So most of us have actually now made sure that we don't use that for our acute laparotomies. So my colleagues actually noticed the same thing. And so that's a really good example of how you can adjust your practice to make sure it's in line with what is the best practice.
Could it also help for the groups or the individuals in the in whatever the circumstance was to understand that it's like people's behavior, even when it's actually caused by those situational factors rather than how they might normally act?
Yeah, absolutely.
And then passing that kind of information on and saying, like, sure, John might have done things that seemed like out of odds with how we'd normally behave, but that wasn't John's normal behavior. It was just because that's the situation that caused it, not.
Yeah, absolutely. Yeah, that's a great point, Ross. So having these meetings, which are separated in time from the actual event, allows time for self-reflection. And especially when it comes up to the point where you're going to present it, you start to go back over it and think about it with the cold hard facts and with less of the emotion that you've maybe been carrying up until then. And certainly if you're still going in quite emotional about it all, afterwards, hearing some supportive things from your colleagues can allow that emotion to dissipate and for you allowed to even reflect further after a peer meeting like that. So it is really, really good for self-reflection practice, which is one of the things that we need to do as professionals.
What Ross says speaks to the culture as well. Having worked in healthcare since 1984, I can tell you the culture has improved exponentially.
Yeah. And
it wasn't always as collaborative and supportive as it is now. And so the sort of error rates were so much higher because you weren't, you were just feeling under so much more pressure and didn't have that support from your colleagues to know that if they've got your back.
Great. So I thought that I'm going to stop share. Sorry. I'm going to talk a little bit about the course now. But before we go on to that, is there any other further comments that people want to share with us, or experiences you want to share in terms of adverse events, and any examples that people have got in their minds that was a great learning point for them?
I can easily, there's one that springs to mind for me.
Absolutely.
I came from a background as a cardiac physiologist, and the culture in cardiology is extremely competitive and not particularly collegial. I can't speak to that now because this was 20 years ago, but certainly at the time it was, if you shared your knowledge, it was considered what's your agenda? You know, you were viewed suspiciously.
Mm.
So having changed to anaesthesia and being a third year trainee, I was preparing a scavenging system on a T-piece circuit on a neonate. So it was a high risk case of a premature baby. And I was looking at the way I had it set up, and the baby was literally coming down the corridor, and just something in my gut told me that things weren't right. But because I knew it was such a supportive culture, I went to the next room and got one of the qualifieds to look over my circuit before the patient arrived. And he pointed out to me that the way I'd set it up would scavenge all the anaesthetic gas and the oxygen before it reached the patient. So clearly not ideal for a neonate. So, you know, it felt like a sucker punch to my gut, but the key learning point for me there was just how supportive that culture was and how much safer it was as a result. And he chose to stay with me because I was so shaken by my mistake. He chose to stay with me for the induction. And once the procedure was underway, we sort of stepped out into the adjoining room. And he was just so supportive, and he decided to tell me about a particular incident that occurred for him when he was a trainee, and something he'd set up wrong that was dangerous. And, you know, like he didn't need to tell me that, but he did to make me feel better. And it was just such a wonderful feeling to be working in a collaborative, supportive environment.
Yeah, great. Thanks very much. Great. Okay, so we're just going to take the last 5-10 minutes just to talk about the course. Some of you have done most of it. Some of you are just beginning your journey, but that's okay. If you could just share on the chat one good thing that you've covered in the course. Just one good thing, if you can think of one good thing that you've covered in the course that you liked, just share that in the chat. Thanks, Sharon. So said the encouragement to give an improvement project a go, even if it is with one patient for one event at one time, just to make a start. That's great. Yeah. So the PDSA approach, it's really powerful. It kind of gives you the first rung on the ladder to go for. That's great. Angela says root cause analysis has expanded my understanding of appropriate process and gave me further opportunity to apply A4 methodology. Yep, so root cause analysis is a really powerful way to dig down into what has been the reason that something bad happened. And it often, it's a really powerful way to demonstrate quite often your gut feeling like this is the reason, but sometimes actually it throws up some interesting findings. But I think the reason that is so good is that when you write a report on an adverse event using root cause analysis, you're backing up your recommendations. You're not just jumping to a conclusion. You've actually shown how you've got to that conclusion, and that is really quite important when you're trying to convince higher management who are quite well removed from the front line, and also may not even have much experience of said event, to actually understand how it could all relate back to whatever it is, like, I know, staffing shortage, for example. Good. Pam says the course on leadership was very informative and helpful, as anyone can be a leader by being proactive at the workplace. Perfect. Yeah. I think in fact, opportunities for leadership are sometimes better when you don't have the responsibility and authority of somebody in that position. For example, a good example that would be, would anybody want to be, it's a question, would anybody really want to be the chief medical officer or the chief nursing officer or the chief allied health officer? Would they really? Because you have a lot of power and a lot of authority and responsibility, and you can probably make a lot of changes happen with a push of a button or a few emails. But their hands are really quite badly tied when they get up there. They've got so many things that so many responsibilities that just pull them in so many different directions, that actually leading on a particular thing is actually now really challenging. And I found that actually the easiest time to lead an improvement project was when I was a registrar and I had no other responsibilities. I just had a passion for doing it, and I went and knocked on people's doors, and sometimes that element of surprise that somebody that they're not expecting is coming to talk to them about something they weren't expecting is enough to sort of like get people to notice. So I think leadership from unexpected people is actually a really powerful form of leadership. And Ross says, I've only just started, but from the outline, I can see the practical skills for leading teams through change or improvement will be super helpful for me. That's great to know. Yeah, thanks, Ross. And I look forward to seeing more of you next year. Great, so thanks for sharing those things. And the last thing I would really want you to share really is, have you used any of your new knowledge or skills? If so, what have you used it for? And if not, how do you intend to? So this one, I'd like to hear from you. So maybe I'd start with Ross, because it might be a bit easier for him to answer. So how do you intend to use your new skills? Maybe just expand on what you were just typing.
Yeah, sure. So this year I've been behind refreshing the Speak Up program. So there's just been like quite a lot of back end kind of work that's gone into setting things up so we can get the Speak Up program like up and running to like a standard that's going to be really helpful for everyone. I think like especially the just looking through the model for improvement would be really helpful, just so we can make sure that our refresh is doing what it's meant to do, but then also that at the end we can see that its impact is, if it's actually been good, or if there's room for even further improvement, which I assume definitely will be the case. But yeah, time will tell, I suppose, with that one.
Yeah, that's great. That sounds like a great project. I really it's a project that you're going to struggle with data and all that hard stuff, really, aren't you? And it's a real sort of people project, really, isn't it?
Yeah.
The Speak Up project's about, people speaking up about bullying and all these sorts of things, isn't it?
Yes.
Yeah. And one thing that just springs to mind, a methodology that is actually made for patients, but actually probably would work just as well for staff, is called experience-based design. And it's where you actually start with, what is the experience of people going through the system? Where are the highs and lows of that journey through it? And, how can we improve that experience? So you would start by finding people who've already done the spoken up about something, and go through that and just find out, what were the highs and lows for them, and where do they think it could be improved and stuff. That would probably give you some powerful information. You've probably already done it.
Yeah, we've got a big archive full of lots of different data points, and some people have had amazing experiences, some people have had terrible experiences, and it's just about trying to figure out from all those data points like what's the best way moving forward.
So a lot of qualitative analysis, emotion mapping, and interviewing and stuff like that. Yeah. Great, thanks very much, Ross. Maybe Pam, can you perhaps share if you've already used some knowledge skills, or if you intend to?
Where I'm working at the moment, I'm working at the doing a COVID vaccination, and it's ever evolving because we've never had a pandemic before. And like the processes that we use will be good for today, and then we'll see something really not working in that process, and we try a different one. We suggest a different way of doing it, and if we see that's working, then we go with it. Like we don't stay on like, oh, this is what we're doing, but if we can improve on it, then we try to do that thing as soon as possible.
And are you involved in as a vaccinator, or are you involved in sort of organizing the setup?
I'm vaccinating, and I'm doing clinical lead as well.
Okay.
So you sort of like see the process, and if there's anything that will improve it, then you suggest it, and then we just go with it. If it goes really well, then it's something that improvement.
It's a really wonderful project to use some of those principles of quality improvement on. I think it probably lends itself really well to lean methodologies, because it's all about processing loads of volume of patients going through, and you probably have some different needs of patients, and so you need to, how do you going to mix that into the same queue? And that is the Toyota production line.
And being flexible and adaptive to the ever-changing MO directives from the Ministry of Health as well. So it's ever evolving.
It's perfect. You know, I could see you could go in, you could do a lovely process chart, you could measure all the tact times, find out the value added times and all the lead times and stuff like that. That would be a wonderful project to do. But good luck to you. That's great.
Thank you.
Sharon, do you have anything to share in terms of new knowledge and skills, either ones you've used?
I mean, I think the course has been certainly helpful for me. I'm also going through a personal project as part of a CASP process for allied health, looking at the way that we transition our teenagers and young adults out of our service into private practice. So this is with respect to hearing loss and rehabilitation of those children, or habilitation. And often these patients can stay in our department from pretty much birth through to 21 years of age. So there's quite a, it's looking at how we can do that better for people, and so certainly I see that as a way of improving the service that we offer as a department. I think on a larger scale, though, I think the course I think has been invaluable in terms of that, I guess, in understanding the sort of people side of what we do, and how communication and that sort of transparent, more honest and open collaboration can only be a good thing. And rather than sort of protecting your own kind of practice, learning off each other, and also sort of just that improving the sort of processes, or the not just looking at individual practice, but looking at the sort of systems that that lead to improvement.
That's absolutely right. It's it's the key to the door in terms of actually making progress and not bashing your head against that door instead, but actually manage to walk through it. So yeah, thank you very much, Sharon. Angela, anything to share with us in terms of new knowledge and skills either already used or going to use?
I think having the new knowledge and skills is a double-edged sword, because you seem to notice things that you might have been oblivious to previously. So if changes are made without perhaps any sort of consultation or auditing process, you ask the people that change them, how are they going to measure whether they're going to, if it's a successful change or not. And yeah, that's been a little bit frustrating. But from my non-clinical role perspective, it's certainly been helpful in a project around growing our allied health assistant workforce. So to gather evidence around that. So we do a program around sort of skill sharing and working at top of scope called the Calderdale program.
Yes.
And so utilizing that and promoting the use of allied health assistants to promote top of scope practice in various allied fields. So there's a good, a good degree of ability to apply the learnings from this course to that, to give evidence around. And because what it's like, if we do what we've always done, we'll get what we've always got. But sometimes people are too busy with business as usual to be able to see beyond that. So to be able to present them with tangible evidence is another tool in the persuasion process.
Yeah, great, good. So some skills there, and sort of like using data, and also communication around patients and working in teams, understanding what makes good teams and stuff. Yeah, fantastic. Well, it's coming up to 1 o'clock, so thank you very much, everybody, for attending, and thank you very much for participating in the course. And some of you will be seeing next year, and I hope you had a good time. There will be a survey that goes out in the next month or so. I'd be very grateful if you could just fill that in as well. Okay, thank you very much, everybody.
Oh, thanks, James.
Cheerio.
Thank you.
Bye-bye.
Bye.